Hello again, I'm Dr. Hung Vu, and our show is America's Healthcare Crisis. The title of our show tonight is The Quality Issue in Cardiology, Part 1. This is part of a series of productions during which I have the opportunity to introduce and profile the so-called clinical champions in different specialties. The clinical champions are the physicians who, by virtue of their knowledge, their experience, and their integrity, are in the position of defining for us what the quality service in their specialty is. And tonight we're going to talk about cardiology. And I'm very honored to have with us three excellent cardiologists in our community, and I'd like to introduce them. Dr. Randy Evangelos, how are you tonight, Dr. Evangelos?
I'm fine. Good evening. Thank you for inviting me to participate in your forum.
Welcome to our show. Dr. Evangelos is an assistant professor of cardiology at Stanford Medical School, and he is the director of the coronary care unit. And we're very honored to have him with us tonight. He is, I guess, the representative of the setting of university practice. And our second speaker is Dr. Robert Constantino, MD. Dr. Constantino is also a cardiologist who has been in private practice at El Camino Hospital for a number of years. And he will be giving us the perspective of cardiology practice in the private setting. And our third speaker is Dr. Philip Lee. Hello.
Hi.
Welcome to our show, Dr. Lee.
Thank you.
Dr. Lee is also a cardiologist and works at Santa Clara Kaiser. So he will give us some idea about how cardiology is being practiced in an HMO. So maybe Dr. Evangelos, you can begin by telling us the overview of the training of a cardiologist.
Our perspective, at least at Stanford, is that being a good clinical cardiologist, which is what I think what we're talking about this evening, not so much a research cardiologist, but a clinical cardiologist means that you have to be a good internist to begin with. And everyone who comes to cardiology training in most cardiology programs around the country has finished a internal medicine background training.
Which is about 4 years after medical
Which right now is taking 3 years.
3 years.
After the finishing of medical school. So there has already had been a 3-year commitment to learning internal medicine. From that point onward, the cardiologists to be really are faced with a rapidly expanding technical and knowledge base in which they're being asked to familiarize themselves both with the new kinds of procedures that are being done for diagnosis and therapy in cardiology, which really include many aspects of interventional cardiology, which takes patients into cardiac cath labs and in which their diagnostic procedures are done to evaluate the nature of their coronary artery disease, their valvular disease, and their heart disease, but also the manipulation of those disease states, the actually changing the status of their coronary arteries either by dilating stenotic vessels or dilating stenotic valves.
Maybe you could define dilating stenotic valves to the general public, you know, in terms of the layman terms.
Well, there are
Block pipe, maybe.
Yeah. Okay. From a plumbing standpoint, blood has to move through the heart in a unidirectional way, and if the valves that allow the blood to maintain a singular direction become stenotic, most specifically the mitral valve that's between the left atrium and the left ventricle, or the aortic valve, the heart becomes limited in terms of its functional capacity. Defining these problems in patients before they really are overwhelmed by the problems has been, I think, the nature of the real progress in cardiology over the last.
So it takes 2 more years after internal medicine residency to become a cardiologist?
It actually now takes 3 years.
3 more years?
3 years after general internal medical training. And in fact, to gain the expertise that is required to do a number of these specific technological procedures, cardiac catheterization lab techniques, electrophysiological techniques.
Right.
Often people will spend another year or two beyond their fellowship. So people are often committing 5 to 6 years beyond internal medicine training to really become expert enough to feel comfortable to take those responsibilities. So often the total training time is 6 to 8 years beyond medical school to gain that expertise. And so there are people who I think initially may have decided that they did not want to become a surgeon because they didn't want to commit 6 or 7 years to this training, who in fact in the end are spending just as much time as a surgeon might spend to gain expertise.
I'm glad you say that, because the audience who watches our show should know that, you know, probably cardiologists are fairly compensated, but not overly compensated for the training that they have gone through, isn't it?
Well, they certainly have committed an awful long time sort of in the learning mode before they really in the practice of cardiology. So there's been an awful lot of time commitment to that, and I think considering the initial commitment to medical school and college, which is 8 years, you're talking about people who are often committing 15 to 20 years actually of educational time to
very difficult skills
to become competent, if you will. And I think that the specialty has been reasonably strict about making sure that people commit that much time before they go into the practice.
Right. Dr. Constantino, maybe you can give us an overview of the latest developments in the field of cardiology. Is there anything?
Well, cardiology has been exciting, I think, with lots of developments for the last 10 or 15 years, and I guess everybody's aware of the impact angioplasty has had on the treatment of coronary disease, and devices similar to the balloon catheter are now being used to treat coronary disease successfully. So it's changed the complexion of what we see in practice, and people with acute heart attacks now have the process interrupted and have heart muscle saved, and frequently get out of the hospital in such prompt time. I'm not sure they really understand the severity often of what's taken place. So lasers, shaving devices, stents, which are little semi-rigid tubes that are put in the coronary arteries, all those things have dramatically improved the treatment of coronary disease. But the advances in prevention, I think, are probably still developing, and a lot of the regression trials being carried on to lower blood fat levels with various methods and reduce risk factors have also been very successful in showing that this process can be slowed down and in some people reversed to some extent, which is very exciting.
Dr. Lee, maybe you can give us an idea what is the spectrum of clinical practice? What kind of heart patients do you see on the average day?
Well, as Dr. Vagelos was discussing, the field of cardiology encompasses a wide number of patient populations, patient groups, from the spectrum of prevention of heart disease and moving into different areas, for example, like coronary disease or valvular heart disease. I think that we have been blessed with having a number of major developments, probably hundreds of them over the last several years, that have really given us an arsenal with which to deal with these medical problems and help our patients.
Now, I'm talking about on the average days, what kind of presentations do you see? You know, how many coronary artery disease, how many heart failures, and things like that? You know,
well, to be specific about what I would see at Kaiser Santa Clara, we do have quite a busy tertiary care center. So we average about 300 patients with myocardial infarction per year, which is quite busy. Cardiac patients comprise about 40% of our patient admissions at Kaiser Santa Clara. And probably the number one diagnosis there would be acute myocardial infarction or unstable angina, and manifestations of coronary disease. As Dr. Vagelos mentioned, resulting from blockages in arteries, patients have angina, lack of blood supply to the heart.
So you say that maybe 75–80% of all the cardiac admissions?
I think probably a good 60 to 75%.
Okay.
The difficulty there is separating patients who have real myocardial infarction, angina, versus those patients who present with chest pain, and differentiating those patients who really have a non-cardiac, non-heart-related illness or a problem, and trying to decide which patients need appropriate therapy.
Right. So the other valvular diseases, pericarditis.
Well, I think the next category would be congestive heart failure, for example,
Okay.
where the heart is not working properly, not working as a pump, therefore fluid
Yeah.
backs up into the lungs.
Yeah.
Arrhythmias we see a lot of, atrial fibrillation, some ventricular arrhythmias, hypertension, and so on.
Okay. I gather you don't treat hypertensive patients. The internist.
Well, no, I think that certainly internists are capable of treating the vast majority of patients with hypertension. I think that when they become, and hypertension is mostly treated as an outpatient
I see.
illness,
Yeah.
long-term chronic.
So you treat mostly inpatients. Is
Well,
cardiology.
we do both. I think that when internists in general maybe are getting to a level of complexity in a patient's care, either with multiple medical problems, or maybe when the first-line medical regimens are not quite as effective,
Yeah,
then they may ask the opinion of a cardiologist to help out.
Right. Dr. Constantino, maybe you can give us an idea about the methods of management and evaluation of cardiac patient, and maybe if you can occasionally define the medical terms, because I mean nobody knows what pericarditis is. I mean if our audience watch, they think that we all have talkers.
Sure. Well, I think just to talk about the type of patients that we see, I think the reservoir of patients with valvular disease has changed in the community over the years. So a lot of the patients with rheumatic heart disease have been treated. And we don't see, at least on the West Coast, a lot of new cases of rheumatic fever. So aortic valve disease and mitral valve disease are non-rheumatic in origin and treatment here.
Are they mostly surgical patients now? I mean, you replace most of those obstructive
Well, I mean, it
valves.
depends. Again, it depends on the severity of the problem, but
Okay.
calcific aortic stenosis, for instance, in older patients frequently presents with the
Okay.
need to replace it.
Okay.
Leaking valves frequently can be treated medically up to a point in
Okay.
time until the leak becomes severe enough to
Now
replace
let's talk
it.
about the tools of the cardiologist beyond the stethoscope. Give an idea about invasive versus non-invasive methods of evaluation.
Well, we have ultrasound, which has been very useful, with now color Doppler flow techniques, which allow us to evaluate leaking valves quantitatively and calculate valve areas, see what size they are. Also look at heart muscle function. We have exercise ultrasound tests for coronary disease, and we have radioisotope techniques to scan the heart for
Yeah,
muscle function and blood flow.
yeah.
So a lot of those have been very helpful.
Yeah. Now, I think it's important for our audience to know the utility of invasive versus non-invasive, because, I mean, ideally we should use more of the non-invasive methods. So how much of a diagnostic capability do you have just using simple non-invasive techniques?
Well, I think the non-invasive techniques have developed where they're no longer simple, and they do give us a great deal of information. We finally, I think, use invasive techniques in somebody who presents with an acute problem. I mean, if they're having a heart attack acutely, we usually take them and do an invasive procedure. For screening techniques, most of the non-invasive testing is done as an outpatient, and it gives us a great deal of information so that you can screen people who don't need intervention. So it's they're safe and they're fairly quick in terms of the results.
Let's see. Let's talk about the quality issue here, because that's the title of our show. How do you define quality medical services in cardiology at Stanford? How do you know that you're a good cardiologist?
Boy, I think that is we probably all define it every night when we go to sleep by whether we can fall asleep or not. But the fact is, I think that's most of us are lucky enough to practice in a community of physicians, and so that there is a standard of care that is established by the community you train with and the community you work with. And there are established guidelines about accepted levels of survival associated with a particular diagnosis. We know that in very large groups of patients, the survival associated with a diagnosis of acute myocardial infarction ought to be this number, and that we watch very carefully at all of our hospitals to make sure that the the numbers at our hospitals fall within, those ranges.
So you're talking about the outcome here, mortality and morbidity, right?
Yeah, as a measure of quality of treatment. Sure. We look at the lengths of stays
Sure.
that our patients are having who fall into various diagnoses. We look at the percentage of patients who are getting the medications that they ought to get with a particular diagnosis. We know that patients, for instance, who have had a heart attack should be discharged from hospital taking an aspirin. That's sort of a uniformly, supported conclusion. And so we regularly sort of assay, our patients who are discharged from hospital to make sure that, that the vast majority are on an aspirin. And if they're not, then we give feedback to the physicians and nurses involved in that capacity, so that we assay quality of care, both as a group and on individuals on that basis. And then at least from the standpoint of the sophisticated level of care on the West Coast, we have a situation where we have ongoing educational programs that almost everyone is either committed to from the standpoint of their licensing and or voluntarily goes to. I suspect that all of us go to one of the major meetings a year that cardiology sponsors as a group, the American Heart Association or the American College of Cardiology, plus various other meetings that have to do with more specialized interests. So you have a fair amount of data gathering about how our patient care is going sort of online, as well as updating constantly from the standpoint of the new knowledge that's coming in, and I think a fair amount of responsiveness on our part to not wanting to get out of date or out of sync with what the rapidly changing. In
the age of managed
care,
care, does the cost effectiveness have anything to do with quality? Say you have the same outcome, but this patient only costs you $1,000, and this patient $10,000. Does that come into play in terms of defining quality?
Well, I think quality is one of those terms that's very difficult to define. You have to define what you mean by quality first of all. And I think that I might define quality of care by educating the patient and motivating the patient to have a healthy lifestyle.
Okay.
So the number of acute interventions and acute hospitalizations they need in their lifetime is minimized.
Sure.
That might be my definition.
You have cost effectiveness in play there.
Right.
Which is very important.
But cost is not directly involved. It's more likely to prevent the acute illness that is involved in spending money. There might be somebody else, though, who's looking at it from just a financial point of view, and their issues for quality are that they want to spend the minimum amount of money to get a good outcome, not necessarily the best. And I think there's a lot of problems now in collecting data and comparing outcomes, because if you miss 10 out of 100 problems, but 90% of the time you diagnose them, somebody might think that's good care, but you wouldn't want to be one of the 10 whose diagnosis was missed because you didn't have your annual heart scan or you didn't have an echo when you should have had it. So, I think it's a complex term, and I don't think there's a simple answer. You have to be very rigid about how you're defining quality.
How about Kaiser?
Well, I think at Kaiser, we certainly want to provide the highest quality of care, but also keeping in mind cost effectiveness. I think that with the new technologies available now, the decision, or what makes it, some decisions that are difficult for us are deciding, which patients benefit from what procedures. For example, we have, in terms of revascularization, patients with coronary disease, as you've mentioned, we have the spectrum of from the most invasive bypass surgery and to least invasive angiography, cardiac catheterization, balloon angioplasty, the more sophisticated stents, rotablator, and so on. Although we have all of those available at Kaiser, the idea becomes, well, We do have a defined patient population. At Kaiser Santa Clara, it's 250,000 patients, 250,000. And we have all of these things available, but in what patient populations will each of these benefit patients the most? Where will it help them have less symptoms, and where will it prolong lifespan and improve longevity and maintaining a good quality of life?
Right.
I think that the way healthcare is now, in terms of the amount of money spent in the United States on healthcare, that seems to be growing. And the idea is to focus on what aspects of healthcare really benefit our patients in a way that money can be focused to do the most good. For example, you might spend the same amount of money on prevention, patient education, working on risk factors for heart disease, namely hypertension, diabetes, cigarette smoking, cholesterol, working on weight reduction, exercise, and so on. And you could invest a certain amount of money there, whereas you could spend money for one person to have a bypass operation, which nowadays would cost in the range of $40,000 to $50,000.
Yes, yes.
And so the question becomes, of course, we need to take care of our patients appropriately, but it would be nice to take care of them earlier, working on prevention, and maybe spending the $50,000 or $100,000 earlier, and maybe preventing the need for bypass operations in 100 patients later on down the road.
Yeah, I believe that's the trend too. I mean, I talked to your chief, Dr. Pearl, and I was very pleased to hear his opinion that it's really crucial to do some prevention, because so far I believe the practice of medicine has been focused on curing, diagnosing, treating, and then a lot of problems are preventable. And
I think the Kaiser system's been quite unique in its commitment to the long-term well-being of their patients. Most of the HMOs in the Bay Area have an average turnaround time of 2 years. This was last year's data, and so that there was almost no commitment to the kinds of preventive care that might not pay off, if you will, from the standpoint of a prepaid plan within a short time, but clearly over the long term would make a big impact on both patients' care and probably in the end, the economics of the situation.
What's unique about Kaiser is the fact that we are a nonprofit, and so among managed care organizations, any money that comes out of the organization from membership dues and so on go directly back to patients, either in the form of research or prevention and education.
I understand the administrative cost at Kaiser is quite low.
It is quite low, and several surveys recently have shown that. Whereas you have other managed care organizations that are for-profit, you shave off the top 10, 15, 20, 30% of your profit each year, and they go to your shareholders. In fact, our shareholders are our patients. And again, we have a very defined patient population. We know who our patients are. We know that if you want to prevent heart attacks in our patient population, we can get to them. And we can reach them by educational means and so on. I was thinking, when we're talking about quality, in the past we have always worked on delivering quality care at a very individual level. We spent our years in medical school, residency, and training, and so on, and acquired the years of experience and over time. And we've each worked on ourselves becoming excellent clinicians and really taking care of our patients in the best way possible. But the trend seems to be now to really work on providing quality on a very large scale, so that we can service a patient population. And well, fortunately or unfortunately, outside organizations are helping us do this by looking at certain quality parameters that they believe do correlate with quality care.
Actually, it's amazing that the premium, is competitive, and it seems to me that the Kaiser system has all the advantages, and yet I don't quite see why. I guess eventually it will, if it really works, probably would be competing the other systems out, because it seems to me that it would cost much less, because of all the factors you mentioned. But at the present time, there's still hundreds of different insurance companies around. So I assume that still there's no one champion yet.
Well, Kaiser's undergoing a lot of change. I used to belong to Kaiser when I was growing up, when I was 5 years old, and I have seen the changes dramatically. It used to be that Kaiser was the low-cost leader. and that patients, including myself, did not mind waiting for quite a long time to see a physician and to get the appropriate care. I think that over the years that there's been a transformation among healthcare delivery systems overall, but Kaiser in particular, and they want to maintain themselves as being a leader in the field.
Yeah.
Right now, that means delivering quality care, providing access to patients.
Yeah. I believe there's another factor in defining quality, and that is patient satisfaction. And that is such a tricky, kind of factor because it can be so subjective. Do you have any comment about that? Because, patients sometimes are happy for reasons that are not totally based on scientific data,
Well, I think it's a real potential danger from the standpoint of you have to be careful about what your measures are. If, in fact, the most important thing is how many minutes a patient waits before they're seen.
Are we running out of time? Okay, we are running out of time, so I think we have to continue our discussion in our second segment. This is Dr. Vu, and our show is America's Healthcare Crisis. The show is The Quality Issue in Cardiology, Part 1, and I'd like to invite you to watch a second segment, which is Part 2, during which I will invite the same speakers to share with us all these wonderful information about the practice of cardiology. Again, I'm Dr. Vu. Thank you for watching. So long. Good night.
Do you love someone? Have you ever cared? Do you miss someone? Have you ever shared? Do you need someone to always be there when you feel lonesome and deep in despair? Do you need someone to dry up your tears? Do you need someone to always be near? Do you have someone to stay through the years?